To see you once again. So today I'm going to talk about multiple myeloma. The way I'm going to discuss this is, first we'll talk about what are paraproteinemias in multiple myeloma and what is the pathogenesis of disease, what's the clinical picture, how they present, the diagnosis, treatment and prognosis. So first of all, we'll start with this case. A 55-year-old man presents to the internal medicine clinic with new symptoms of exertional fatigue. He is otherwise well with no significant past medical history. His hemoglobin is 10.6 with an MCV of 92. He has normal serum ferritin, vitamin B12, folic acid levels. WBC count 3.8. Absolute neutrophils are 1.3 and platelet count is 117. So what do you see so far? What are the problems in this patient so far? Anemic, very good. Neutropenia. What about the leukopenia? Yes. Then the serum creatinine, calcium and albumin, they are all normal. A serum protein electrophoresis is performed that demonstrate a monoclonal IgA protein of 4 gram per deciliter. A skeletal survey shows occult lytic lesion in the skull and bilateral humeri. A bone marrow biopsy shows 30% involvement by abnormal appearing plasma cells confirmed by CD138 positive immunohistochemical stain. Now, how much you know about serum protein electrophoresis? When is it done? Yeah, when is it done? In general, when will you perform serum electrophoresis? Sorry? Hemoglobinopathy, very good. You can detect what type of hemoglobinopathies are there. But what about the proteins? Total proteins, albumin, globulin or serum electrophoresis. When you decide that I should not only send it for total protein, I should send it for serum electrophoresis as well. Yeah, why not do the immunoglobulin counts then? You can measure IgG, IgA, IgM, you can measure them. So just keep this question in mind. I'll answer it in context of clinical, picture, so you will understand it better. Then the occult lytic lesion, does it mean anything to you? So when you see X-rays, skull, humeri, do you see occult lesion, lytic lesions? What does that mean? Metastasis, a possibility, yes.
Crystallized calcium or
Okay, I'll use two terms. What does bone resorption means? Sorry? Demineralization. Excellent. When the calcium is taken out of the bone, such things will produce lytic lesions, okay, like punched out lesions. Then 30% involvement by normal appearing plasma cells. So there is 30% of plasma cells. We'll talk about this also in detail. And what is CD138 positive staining? Now interpret the previous findings. So far we have got anemia, leukopenia, neutropenia, platelets are reduced as well, and anemia. And lytic lesions on the X-ray, and plasma cells are 30%. So what is the differential diagnosis of this condition? What should you think of?
Maybe bone marrow failure.
Something going on in the bone marrow, most probably myeloma. Okay, myeloma is a kind of a specific term, plasma cell dyscrasias, okay, or plasma cell neoplasms. Any tumor, can be benign, can be malignant, of the plasma cells. Now this is the list of possible differential diagnosis. It's basically in 3 categories. So I don't know if you can see from this slide. One is called as plasma cell myeloma. This is one category, okay? The second is plasmacytoma. This is another category. Then the third is immunoglobulin deposition diseases. This is the third category. So these are 1, 2, 3. These all come under the plasma cell neoplasms, and as well as MGUS, monoclonal gammopathy. It's basically, now it's considered that it's the start of these diseases. So basically the patient maybe 15-20 years ago have this kind of a situation, later on they develop plasma cell myelomas. So another thing, do you see here osteosclerotic myeloma, POEMS? Just I'll tell you what does that mean. It is actually a combination of features. So here you can have organomegaly, endocrinopathy, polyneuropathy, and monoclonal these immunoglobulins, and its skin involvement as well. So this is just a combination. Later on when you look at the slide, don't be confused by what is this POEMS. So I'll explain to you all these. How is the presentation of plasma cell myeloma patients, plasmacytoma, how this differs from these, and finally what are the immunoglobulin deposition diseases. So we'll talk about all these one by one. First thing is, we have to understand what is paraproteinemia. All of you know, so I asked for one question, why will you do serum electrophoresis? You know, what is the need of serum electrophoresis? So if you do total protein or albumin globulin, it will just tell you whether the albumin or globulin quantity is okay or not, okay? And if you look at this green graph, you know, which is behind this purple which is in front, this is, so electrophoresis, 2 electrodes, the positive electrode, because of the electrical current and the size of the protein, they will move on the gel, okay? And the first, this part, this is the concentration of albumin. Then comes this whole thing is globulin. Which globulin? Alpha 1, alpha 2, beta 1 and beta 2, and then finally gamma globulin. Okay, so this is the serum proteins, how they are lined up based on their concentration. Albumin is very high, its concentration is maximum. Then are the globulin. First is alpha 1. Any example of alpha 1 you know? Alpha 1 antitrypsin in emphysema. Then beta 2 microglobulin. We'll talk about that today as well. Gamma globulins, all the immunoglobulins, they lie in this part. The normal graph is albumin like this high, then alpha 1, alpha 2 small, beta is also small, gamma is also small. So this is all the normal proteins. Okay? In paraproteinemia, what is happening? The gamma has gone spiked up very high. And if you look at these, the albumin and the globulin, they are now parallel to each other. You know, they are so high and so big, they are parallel. That's why it is called as paraproteinemia. A big protein spike in the gamma globulin, which is equal to the albumin, so much in quantity, and they are parallel to each other. That's why it is called as paraproteinemia. Okay? Then another thing is, it is also called as monoclonal gammopathy. Why it is monoclonal? Because only one plasma cell is producing all these immunoglobulins. Now I'll ask you one question. If I say the gamma globulins have become so high, you know, it's too much, maybe 30-40 times more. So have the immunoglobulins increased in the body? Because this gamma region has only immunoglobulins, IgG, IgA and IgM. So looking at this spike, have your all immunoglobulins increased because of this spike? Okay, what is this only this one? The answer is absolutely correct. Just let's say, I will give you an example. If the immunoglobulin is against malaria, only malaria, we are not talking about any other pathogen. Just for malaria, these all immunoglobulins are just against malaria, only monoclonal, against one pathogen. The rest of the immunoglobulins, IgG, IgM, IgA, they are all reduced actually. It's a totally different thing because it takes over, the rests are reduced. So even though you see such a high spike of antibody, gamma globulin, but it's just one type of antibody. Maybe against malaria, maybe against typhoid, just one. the rest immunoglobulins are reduced. So far we are clear. That's why it is called as monoclonal gammopathy or paraproteinemia. So these two terms are clear to you now. Now if you look at these, this full group is of cancer or neoplastic, and this one is of benign conditions in which you will see these paraproteinemias. The group that I showed you earlier, the previous slide, they have all these: multiple myeloma, solitary plasmacytoma, monoclonal gammopathy, Waldenström macro. I will explain all these so that it makes sense to you. So these are all the neoplastic conditions, and then these ones are the benign conditions. HIV infection can also lead to monoclonal rise sometimes. Now this will just take you back to your basics little bit. The first thing that happens in the body regarding B cells is so from bone marrow comes your B cell. This is immature B cell, okay? This immature B cell goes to the lymph node. In the lymph node, there are, I'm drawing just a very big germinal center or a follicle. So this B cell is naive, immature B cell. Then it becomes mature on the way. What does that mature means? That it has got IgG and IgM surface, IgG and IgM on its surface. Then it enters here and it encounters the antigen here, and then it interacts. So let's say this is the T cell area. Here the T cell and the B cell interacts. So first it's activated here, it moves out here, it interacts with the T cell, then come back into the germinal center. Here they produce short-term plasma cells. So against any pathogen, the B cells come from the bone marrow, enters the lymph node, encounters the antigen for the first time, then it's go to the T cell area, talk to the T cell, come back here, then here somatic hypermutation take place, and they at this area they produce short-lived plasma cell just for a few weeks. They go back here, do the class switching and somatic hypermutation, so the perfect fit against the pathogen, and now the plasma cell that are produced, they are long-term plasma cells. These are long-lived plasma cells, okay? They will travel back to the bone marrow, and then for the rest of the part they stay here in the bone marrow. Now in multiple myeloma, what is happening? That one long-lived plasma cell that has traveled back from the germinal center to the bone marrow, it become mutated. We'll talk about which mutations, and then it just start producing nonsense immunoglobulins non-stop, and that produces the spike. Now it can be IgG producing, it might be IgG producing, it might be IgM producing, might be IgA, or the kappa and lambda chain, light chain producing, because it's an abnormal plasma cell. You know, it might sometime produce lot of IgG, heavy chain, sometime lot of light chain, kappa or lambda, or a normal IgG, but in abnormal quantities. Okay, so all the list, now we'll go to the list and see one by one that you have heavy chain disease, light chain disease, IgG kappa, IgG lambda. So different types are based on what they are producing. And if you look at this figure, here are certain zones. You know, this outside is the marginal zone, mental zone. The B cells are coming from the bone marrow as naive cells, and they are going through different stages. Now this is to do with the, when you do, you know, the identification of the cells, they have certain receptors on their surfaces, and those receptors are based on from where they are coming. So in case of the multiple myeloma, the plasma cell has already come out of the germinal center. Look, it has come out here, plasma cell, and it has to go back into the bone marrow. It is lodged back into the bone marrow. These ones which are in the initial stage in the mental zone, their features will be different. They are kind of naive and in the going to be a mature phase. So to identify the lymphomas, chronic lymphocytic leukemia, diffuse large cell lymphoma, or multiple myeloma, they are coming from different stages, and these are the stages actually. Whether it is outside in the T cell area, whether it is in the germinal center area, whether it is in the mental zone, marginal zone. That's why you will hear marginal zone lymphoma, mental zone leukemia. So the source or the origin is very, it's going to help you understand the markers on the surface of the cells and where they are present. So as far as,
So the receptor expression is dependent on which side the cell is present.
At which place and at which stage. This is very important. That's why they have these names. So this figure is not just related to this lecture. It's kind of very broad. If you see how many things have been written here. So for example, this particular area is the germinal center. Okay. This one is the mental zone. This one is the marginal zone. Now at each stage, I gave you this example so that you understand that B cells, they come from the bone marrow as a mature cell, enter the lymph nodes, go to the germinal center. I have not drawn here the marginal zone and the mental zone because it directly go to the germinal area and it first recognizes the antigen. Then it comes out back into the T cell area. Then they interact with the T cell. Once it interacts, it has to go back. So in the first phase, they produces short-lived plasma cells for 1 to 2 weeks, and they are not a perfect fit. So they go back here, then the follicular dendritic cells show it, then they produce the perfect fit cells, and those perfect fit cells are now long-lived plasma cells. They will, and class switched as well, maybe IgG, maybe IgA, depending on the pathogen. Then these plasma cells come back to the bone marrow, and then they stay there for life. Another thing is, the more you get infections, the more this permanent library of long-lived plasma cell will increase. That's why my IgG library, if I had typhoid, malaria in my life, those plasma cells, long-lived plasma cells library will have those. Someone else has a different repertoire of infections. So everyone's long-lived plasma cells are different from one to another, even though they are IgG. But in this case, what happens? These long-lived comes, they have mutation. Now they start producing very bad IgG for whatever reason they were produced. That's why they are monoclonal, and this source will help you understand. So maybe if you just memorize mental zone is like this, they have this receptor. No, it won't work like this. If you remember the whole story, what is the purpose of germinal center? What is the purpose of mental zone? What is the purpose? Here they are in pre-B cell stage, so definitely they will have this receptor. Now if they are plasma cell, they will have this receptor. So the diagnosis, when you do it on hematology or immunohistochemistry, you will easily remember the whole mechanism if you remember the source from where they are arising. So this figure is important. Don't just go for memorization. So kind of remember this whole thing. It will help you understand the rest things. Okay, and the peak so normally from 40 years to 70 years is the time where you will find a lot of the patients, but the peak incidence is around 70 years of age. Our scenario was 55 years of age, okay, the patient that we started our case today. Then in black it is much more as compared to the whites, and definitely it is above 40 years of age that you will find patients of plasma cell neoplasms. Now here there are certain questions. First look at the questions, then I'll try to explain the diagram. Is there any, this is actually a wrong word, is there any basically mutation of genes? Which factor prevent myeloma cells from apoptosis? So the long-lived plasma cells that go in the bone marrow, what keeps them alive for years and years? And what is the cause of osteolytic lesion in multiple myeloma? So we are specifically talking about why there is osteolytic lesions in the multiple myeloma in the first place. So these are the myeloma cells, basically plasma cells in the bone marrow. Now, when they will start multiplying at a very heavy rate, what will happen? An obvious reason is they will suppress all the other resident cells in the bone marrow. That's why total leukocyte count reduced, neutrophils reduced, platelets reduced. So that one thing is they are suppressing the other cells in the bone marrow. So that's a very obvious reason. When you will look at the bone marrow biopsy, the plasma cells are only 1%. Normal plasma cell count in the bone marrow is 1%. But in these patients, it rises up to 30%. So of total cells, 30% will be plasma cells. Okay? So one is bone marrow infiltration. They are suppressing all the other lineages in the bone marrow. So they will definitely, and this suppression and this pushing can also result in bone, mass. So which bones they involve? Of course, wherever is the bone marrow, whether they are the long bones, the vertebrae, or the other bones. So they tend to have mass as well. Now, decreased immunoglobulins, it makes sense because monoclonal immunoglobulin rise, rest of the immunoglobulins are reduced. Neutropenia and infections. So which type of infections would you suspect? Bacterial. All the bacterial infections, especially the extracellular ones, which are dealt by the immunoglobulins, and streptococci, staphylococci, E. coli. These are the main bacterial infections that you will see in these patients. Then the monoclonal protein will cause also, do you understand what is the difference between radiculopathy and neuropathy? What's the difference between neuropathy, peripheral neuropathy, or radiculopathy? Excellent. So when the nerves are coming out of the spinal cord, if in the spinal cord, let's say the vertebrae have collapsed, they will suppress the roots. So if that happens, it's going to result in radiculopathy. And if outside, after the roots, in the peripheral nerves, if there is damage, that will be peripheral neuropathy. In these patients, you will see both of them. Why? Because the bones, so they will produce IL-1, IL-6, they will activate RANK-L, that is an osteoclastic factor, and the bone resorption will start. They will start taking out calcium from the bone, putting it into the bloodstream. So instead of going and depositing in the bone, they will start it taking out. This is called as bone resorption or osteoclastic activity. Okay, so it's under the influence of IL-1, IL-6 produced by plasma cells, and it will activate RANK-L. I'll show you. These all will together take out calcium, so the bone become weak, and the lesion that you see is called as lytic lesion. So gradually the vertebrae, they can get compressed, they can get damaged, and that damage will press the nerves. So you get radiculopathy or neuropathy. And amyloid. What is amyloid? Amyloidosis is characterized by deposition of polymerized proteins. So when we talk about immunoglobulins, whether it is heavy chain, light chain, these can get polymerized and deposited in the heart, in the kidney. So they can cause, if it is light chain, it is called as amyloid AL. That is light chain amyloidosis. If it is a heavy chain amyloid, yani the heavy chain got deposited, it is called as amyloid H, heavy chain amyloidosis. So amyloid is deposition of the light or heavy chains in different organs because they are too much, they are uncontrolled, polymerized, deposited, and that can result in renal failure as well. There are different reasons. Hypercalcemia, because calcium is coming out of bone, increasing in the blood. Hypercalcemia can cause damage. Increased amyloid protein can cause damage. That's why you can see here that the monoclonal protein is leading to amyloid. Monoclonal protein is leading to renal failure. Then another thing is, gradually protein levels are increasing, plasma level is reducing, so the blood is becoming thick or hyperviscosity. So the viscosity of the blood is increasing. That's why it's also called as hyperviscosity syndrome caused by the monoclonal proteins. So now think again, plasma cell suppress all the other proteins. So the bone marrow, what? All the cells are reduced. Platelets, lymphocytes, neutrophils, they are all reduced. Then it pushes the bone, so you see bone lesion. It take out calcium from the bone, the lytic lesions are formed. When the calcium is taken out, hypercalcemia that can cause nephrotoxicity. The light or heavy chains, they polymerize, deposit in the tissues, it leads to amyloidosis. Heavy chain or light chain, that also leads to the renal failure. And the protein levels too high in the blood, it becomes thick and viscous. So hyperviscosity occurs as well. So now these are all the things that I mentioned, that myeloma cells, they will go into the bone marrow and they will join the fibroblasts and the stromal cells in the bone marrow. That keeps them alive. So when they go here, they lodge back into the bone marrow, they find here stromal cells, they give them survival signals. So they will survive because of those signals. And that inhibit their apoptosis, and they can stay there for as long as they like. They also produce IL-1 and IL-6 that activates rank L, and this rank L has got osteoclastic activity. Okay, now with respect to osteoclastic and osteoblastic activity, just remember, you can do a bone scan and you can do a PET scan. What is the difference, with respect to the osteoclastic and osteoblastic activity? Which can detect what? So the nuclear scan that you do, you inject the dye, do a bone scan, and you also do a positron emission tomography. What's the difference between these two? Bone scan can detect osteoblastic activity, bone formation, but PET scan will detect osteoclastic activity. So they are doing
Again, spelling of the second one.
positron emission tomography, PET scan. It's short form is PET. Okay, 1 second. So you have got bone scan or a nuclear scan, and one is called as positron emission tomography, PET scan. This is for osteoblastic, and this is for osteoclastic activity. Just in general, they have many uses, just a very simple thing to remember. So in multiple myeloma, which one you will ask? PET scan. And it is under the influence of this rank L, IL-1, IL-6 produced by the plasma cell. Then what type of mutations occur? If you remember the B cells here, once they are activated, they normally mutate many times and they produce thousands of B cells, and they try to check which one is the best fit. The bad fits are deleted, the good fits are kept for lifelong. Now they are already going through the gene rearrangement, and at this stage there you can see that around 35 types of mutation take place in these tumor cells. So when the plasma cells or the B cells are multiplying, they can go through mutations. Heavy chain 14q chromosome can get mutated. Then there is something called as cyclin D1, D2, D3. These genes can get mutated. MYC and RAS genes, they are also sometimes deleted or mutated. So these are the possible deletions that are seen in multiple myeloma. And at this stage. Now read each question, and I hope so far we'll be able to answer all of them. Bone pain, especially backache. Why? Osteoclastic activity, bones are weak and patients have pain. Features of anemia. First, which features you will see? When somebody has anemia, they have fatigue, pallor, excellent, shortness of breath. So you will see these features. Recurrence infection. What is the cause? Which infections? Streptococci, E. coli, and features of renal failure or hypercalcemia. Resorption of bone, calcium increase, and it has nephrotoxic effects, and also because of the amyloid protein, light chain or heavy chain. Abnormal bleeding tendency. Why? Thrombocytopenia, platelets are reduced. Very good. Amyloidosis occur in 5% of the patients. Hyperviscosity syndrome, 2%. What are the features of hyperviscosity? Headache. Very good. Headache, stroke, thirst is increased, and sometime blurring of vision. These are the hypertension. And this again is the whole thing, which we saw previously.
What's the cause of hyperviscosity?
Because immunoglobulins are too much. When they become too much, protein is increased. That's why the plasma fluid component is reduced.
Doctor, the third one,
Recurrent infections, streptococci, staphylococci, E. coli. That's why they are more